And we're going to start with Dianne Laroche, who's the clinical practice leader and risk manager at Campbellford Memorial Hospital, one of the hospitals that has terrific completion rates. And she's going to present on using HOBIC data to examine dyspnea for patients with COPD.
I want to thank ISIS and the HOBIC group for allowing me to come and tell our story. And that's basically what it is our story with HOBIC. You see that we're talking, it says CHF up there, and your paperwork says COPD. I will get to that piece of it. It is, they do jive. Okay, so I'll tell you a little bit about Campbellford Memorial Hospital. We are a small, and I do mean small, 34-bed acute care hospital in the Trent Hills, which, if nobody knows where that is, it is south of Peterborough in the middle of God's country. It is very much a recreational area. It serves about 30,000 residents from 3 different counties. So that would be Northumberland, Peterborough, and Hastings County. 22,000 emerge visits a year and 1,100 admissions a year. Okay. So just to give you an idea of the growth rate there, by 2036, we're looking at our senior population expecting to grow by huge numbers. Huge numbers. So what's our HOBIC history? CMH, we began working with the project with Dot and Peggy and Tracy. 2009, in that area, 2008, 2009, we began to look at it. It started off with us looking at the admission, history, and assessment, and how they could have some continuity with that across the LHIN. And then the HOBIC piece came in with the therapeutic self-questions, and we saw it as a big opportunity for us to kill 2 birds with 1 stone. So by March of 2009, we went live. Okay, so we began with data collection. We began to monitor it through the HOBIC reports post-go live in 2009. Our initial focus was around getting good completion rates. That's what we focused on. We didn't even really look at the data part of it and what we could do with it. That did help us though, because we are a small hospital and our completion rates, I'm happy to say, are pretty good. The auditing was sporadic, but we've reached the point where we felt we really had to move on to the next thing. So then we began to think about the possibilities. So what can we do with this information? What's there for us? And we don't have, like, we're not a research facility. We don't have a lot of techno programs and tools that will allow us to, punch data in, pull up a crystal report, do your thing. Unfortunately, we don't. So we had to look at what we could do. So we utilized the existing data to evaluate the outcomes. So initially we began with identifying what our top 5 CMGs were, which we already knew, and how specific indicators could be pulled out of that existing HOBIC data that would provide us with information on nursing outcomes, which, as everybody knows, is one of the big reasons behind HOBIC. We recognize that both CHF and COPD were high on our list of CMGs. There was a small focus group of nursing staff put together who would look at that stuff and would provide us with the evidence that the patient had improved at the time of discharge. So we ended up looking at fatigue and dyspnea and felt that if we looked at the admission and looked at the discharge data for patients, what could we pull out? The decision was made to develop a process that would allow us to test that. So what we did was we had health records print us off from their reports, their coding reports, what patients were admitted at initially with CHF. So we took those, we had to hand pull the charts. Now mind you, we're a small facility. We're not talking, we might pull 4 charts, we might pull 10 charts. But to pull more than 10 at any given time, as long as we didn't leave the time period too long, was pretty easy. So it wasn't really a labor-intensive process at that time. So they would pull the sheets, I would pull the charts, then I would take and look at each, because we print off both the admission and the discharge pieces, they're within the chart. So if they were done, they'll be there. So I would take them, pull out the information, see what the rating scores were for those patients, and as soon as you do it, you could automatically see whether somebody improved or they didn't improve. So I would take that information, take it to the staff level and say to staff, you guys have been doing this information, look, here's proof that the nursing outcomes are there, that you can see what work you've done, you can see how well the patient has done, or maybe where we need to do some improvement. For next steps for us is looking at collating and identifying more opportunities for quality improvement. We are looking, and the Lynn had a bit to do with this because of some of their programs around readmission rates for COPD and CHF, and the fact that they are some of our top CMGs. So we put a group together, it's a multidisciplinary team, and they have developed a program that educates patients with CHF and COPD. So it's a couple hours, 1 day a week for, what is it, Carrie, 6 weeks? 6 to 8 weeks? 7 weeks. Actually, Carrie Shudall, who's with me today, is running that program. She's our discharge planner, and she looks after some projects. So this program has been put in place as a means of improving, because we saw that patients were doing better with a little bit of help. So if we can improve their education about their disease process, managing their meds, managing their symptoms, and looking at people who are early stage versus a lot of the ones that get admitted, which are end stage. So it is either physician referral, family referral, nurses or any of the staff, physio or nursing can encourage a patient and family to participate in the program. So they are on their second set of rounds. So, and we've started to integrate COPD. So the Integrated Chronic Disease Management Program, as I said, is multidisciplinary. It's a 7-week program and consists of education provided by nursing, physio, pharmacy, dietitian, rec therapy, and other community resources. Program is presently being evaluated, so we're using a survey for patient information to get feedback from them on how they feel they're getting information. Do they understand the program? Do they understand the information? What can we do better? What are we doing well? And the evaluation should identify opportunities for improvement. So measuring success, continued success and completion rates for both admission and discharge HOBIC is what we're looking for, especially the therapeutic self-care questions. An increase in the numbers of attendees at the program, taking the opportunity to participate in that program and improve their health. The decrease in avoidable readmission rates for CHF, and COPD, and to date we have seen a decrease of readmit rates in the second quarter of this year by 75%. Now that's a whole 4 patients, but when you have a 34-bed hospital, 4 patients is a lot. So how could we improve? One of the things that we would like to look at, and actually the presentations this morning have been helpful to me because I see a little light at the end of the tunnel. We want to be able to drill down some more and be able to get information that is disease specific. So that part that we were talking this morning about diagnosis, so where's that piece, or how can we do that, Walter, where we can pull off the information that says what a patient's diagnosis is, so we can pull out the COPD patients, pull out the CHF patients, pull out the chest pains, whatever it is, and be able to use that information and correlate it. It just makes it easier. It would make it so much easier. So, but we appreciate the reports that we're getting. I'm really looking forward to what we're going to get this month. And I think that those reports, those kinds of things have really helped sell HOBIC for our organization. And it does have a lot of support, but it also has helped us a lot too, and our patient population. So that's it for me. Oh, don't clap. Anyway.